Bien, y ahora tenemos el gusto de presentarles al profesor Ayman Jurdi de Estados Unidos con su ponencia Xenotrasplante, Avances y situación actual. El profesor Jurdi es médico nefrólogo, especialista en trasplante renal y enfermedad glomerular en el Hospital General de Massachusetts. Completó su residencia en medicina interna en el New York Presbyterian Well Corner Medicine, donde se desempeñó como jefe de residentes médicos. Obtuvo una beca de investigación en nefrología en el Hospital General de Massachusetts y en el Hospital Brigham and Women's, donde realizó una formación avanzada en enfermedad glomerular y onconefrología. Entre sus publicaciones y principales logros se destacan relacionados con los temas de tratamiento de la enfermedad renal autoinmune, rechazo del trasplante de riñón y la recurrencia de la enfermedad glomerular posterior al trasplante, la prevención de las complicaciones de la inmunosupresión y la optimización de las respuestas a las vacunas en personas con enfermedades autoinmunes y trasplante de órganos sólidos. Actualmente se desempeña en la atención a personas con enfermedades autoinmunes y glomerulares en el Centro de Vasculitis y Glomerulonefritis del Hospital General de Massachusetts y a personas con trasplante de órganos en el mismo centro de trasplantes. Actualmente es instructor de la Facultad de Medicina de Harvard e investigador del Centro de Ciencias de Trasplantes del Hospital General de Massachusetts. Bienvenido, profesor Jurdi, a este quinto simposio internacional del programa Donación y Trasplantes de la Subred Norte de Bogotá, Colombia.
So I guess we'll go ahead and get started. My name is Ayman Jurdi, and I'm a transplant nephrologist at Massachusetts General Hospital, and I'm an instructor in medicine at Harvard Medical School. And I'm going to be presenting today about xenotransplantation, current state, and future. Next slide, please. Okay. Okay. Great. Can you guys see my slides? Okay. Okay. So I have no disclosures. The objectives of the talk today are we're going to recognize xenotransplantation as a potential solution to organ shortages, to understand the immunologic barriers to successful xenotransplantation, and then to review recent advances in xenotransplantation, and then to review the physiology and the projected role for xenotransplantation in the treatment of end-stage kidney disease. So why is this topic important? This topic is important because obviously of the huge wait list for kidney transplantation for human organs, and because the gap between sort of demand and what's available. And so what I'm showing you here is data from the SRTR, which looks basically at all the outcomes of kidney transplantation in the United States. And what you're seeing in different colors is basically which patients, after being listed for kidney transplant, are either still on the waiting list, got transplanted, died on the waiting list, or were removed from the list after, up to 3 years post-transplant. And what you can see is that at 3 years post-transplantation, from the people who were listed initially for transplant, only about 30% are transplanted by then. What you can see is that about 30% of people are still on the wait list 3 years later. About 10% of people die on the wait list 3 years later, and about 20% of patients are removed on the wait list for being too sick within 3 years. So there's a very big need in sort of shortening the wait list time so that we can actually give access for these people so that they can get kidneys sooner. And one solution that's been proposed to this is xenotransplantation. And so I was sort of looking back at the history of xenotransplantation, and this concept is not a new concept. So the first xenotransplant which was a pig-to-human xenotransplant, was actually performed in 1906 by Dr. Jabalaib, who was a surgeon in France, and he actually was helping treat people with chronic kidney failure. And what he actually performed one of the first pig-to-human xenotransplants, or probably the first one, in 1906, so over 100 years ago. And at that point, that was done as a vascular anastomosis to the elbow of the patient. And obviously, unfortunately, that failed, and the patient made urine initially, and then the kidney thrombosed on post-op day 3. But the point of this is that this concept as a potential solution for renal failure has actually been around for a really long time. But now we have a lot more information and a lot more advances in this field. And what I'm going to talk about is first, what are the potential benefits of xenotransplantation, why pick the pig specifically, and how far we've gone. So what are the potential benefits of xenotransplantation? So the obvious benefit is that xenotransplantation can increase the supply of donor organs and reduce the mismatch between the demand and the supply. The second thing, which a lot of us who take care of transplant patients know, is that disease donor kidney transplant is very unpredictable. It can happen in the middle of the night, and it can happen, at times when maybe it's not optimal for people, for example, who are on anticoagulation and have mechanical heart valves or have antiphospholipid. And so potentially xenotransplantation can also make some of these previously done disease donor kidney transplants and actually a planned elective procedure, where especially for complicated patients, we can actually sort of plan when the surgery is going to happen, plan the anticoagulation, plan the antiplatelets, etc. So that's the second benefit. The third benefit is increasing the rate of transplantation for borderline candidates. So I think a lot of us who care for these patients know that we see some of the older patients who may not be able to wait 3, 4, 5 years on the wait list, but we think that for a short period of time, like let's say over the next year or so, that these people can potentially be candidates. And so having the xenotransplant option could potentially actually allow us to transplant these borderline candidates in the next 6 to 12 months, while they're still candidates for transplantation, when they may not be candidates, in 3, 4, 5 years. So these are the potential benefits. So when we think about xenotransplantation, then the next question is, okay, so what animal should be used for xenotransplantation? And the animal from which there's the most data is our pigs, or porcine xenotransplantation. And there are pros and cons to using pigs in this setting. The pros of using pigs for xenotransplantation is that they have a similar organ size and function in terms of their kidneys. So they are organs that we expect to work similarly. They have a short gestation. So to breed the pigs with a certain genetic background and then grow the pig, etc., it's the time it takes to do that is shorter than other mammals that we could potentially use. And then the last thing is the pigs are already used in medicine for heart valves, for cartilage, for other things. And so there is a potential to sort of expand on that. And there's public acceptance in a lot of places for using pigs specifically in this context. What are the cons? The cons for using pigs for xenotransplantation are the immunological barriers, which we're going to discuss in more detail. There are also important physiologic differences in the complement system and endocoagulation systems between pigs and humans. And then there's always the zoonotic infection risk, which is basically the risk of potentially transmitting an infection from the pig to the pig organ to the human, although this is not unique to pigs specifically. But really, because I think specifically because of the short gestational time and the similar organ size and function, the pigs have been chosen to be sort of the forefront animal for xenotransplantation. And if we look over time, really this field has come a long way. And what I'm showing you is the survival of pig organs and pig to non-human primate xenotransplantation over the years. And when this all first started, the organs would last days. And then in the late 1990s to early 2000s, they would last weeks. But really, over the last few years, we've had organs that have lasted over 1 or 2 years. And so this is why this is now being translated to humans. And so what has made this field advance so much? Why are the organs doing better? And why are we now looking at doing this in humans? And I think there are 4 main advances in xenotransplantation over the last 30 years that have made this possible. The first one is the genetic modification of the pigs using CRISPR-Cas technology so that we can alter some xenoantigens and some of the complement and coagulation systems. The second advancement is improvement in the immunosuppressive regimens in this context, specifically the addition of antibodies against CD154 for complement blockade, which has really advanced the field of xenotransplantation. Third is actually the recognition and the ability to inactivate endogenous porcine retroviruses that the pigs have embedded in their genome. And then lastly, the advancement in pig to non-human primate models over the last 20, 30 years that has really given us a lot more information about how to successfully go about this. So when all of this started, hyperacute rejection was a huge problem in pig to non-human primate kidney xenotransplants. And so when people were doing wild type transplants, which means that the pig is not genetically modified at all, hyperacute rejection within minutes to hours was the typical outcome. And what you can see here on the left is pig xenotransplant into a non-human primate. Immediately after reperfusion, the kidney looks good, it's pink, etc. And then, a few hours later, the kidney is necrosed, and because of the hyperacute rejection and thrombosed. And so early on, this was a huge burden and a huge hurdle to the progression of non-human sort of xenotransplantation. And some of the experiments that led to the recognition of the cause of this have happened over the years. And this is one I want to highlight from the 1980s, where they actually did plasmapheresis for the monkeys before transplantation of the pig xenotransplant kidney into them. And what they noticed is that if you perform plasmapheresis, that you're actually able to delay rejection or hyperacute rejection of the kidney transplant from minutes to hours to about a week after transplant. And so this was one of the first evidence that suggested that there was a circulating factor that was causing this, which was thought to be most likely an antibody directed against pig antigens. And so this was sort of one of the earlier experiments that made us recognize the importance of thinking about incompatibility, especially sort of preformed antibodies against the pigs and against specific antigens for the pigs. So one of the first advancements in this field is actually thinking about the role of the complement system in the rejection of xenotransplantation and in allograft injury after xenotransplantation. And as we know, the complement system is involved in ischemia reperfusion injury and is also involved in antibody responses. They're an effector mechanism for antibody-mediated rejection. And so in the late 1990s, there was a lot of thoughts about whether potentially overexpressing genes for complement regulatory proteins, which are proteins that downregulate the complement pathway, can potentially have an impact on xenotransplantation. And so one of the experiments I'm showing here is actually a pig to monkey xenotransplant where there was basically insertion of the human CD55 gene, which is a complement regulatory protein. This was injected into the pig genome and overregulated to have sort of high supraphysiologic level of the activity to downregulate complement activation. And this kidney was transplanted into non-human primates, into 6 non-human primates, which are shown in the first 6. And the outcomes of these kidneys were compared for 6 other monkeys who received kidneys from basically wild-type pigs that did not have this human CD55 complement regulatory protein basically inserted. And what they found was that in the pigs that had the human CD55 complement protein inserted, that only half of these pigs actually developed rejection, and that some of these pigs actually survived, the kidneys survived 4 or 5 weeks. But in the pigs in whom did not have this human CD55 inserted into the genome, all of the kidneys had either hyperacute or an acute antibody-mediated rejection. So this was one of the first evidence that actually overexpression of complement regulatory proteins as transgenes in the pigs could potentially also delay rejection. So far what we know is that removal of preformed antibodies before transplant delays rejection, and that overexpression of complement regulatory protein can also delay rejection of xenotransplantation. And what they also showed in the study is that when they looked at the kidneys after explantation, was that there was much less deposition of complement products such as C3, C4, and C5 to 9, sort of consistent with that, with the hypothesis that this is probably driven by the reduced complement activation. The next major milestone in xenotransplantation was the recognition of the pig carbohydrate xenoantigens as important immunologic barriers. And so a lot of the preformed antibodies against pigs are actually, directed against carbohydrate antigens and not protein antigens necessarily. And this was one of the first experiments that looked at this, where basically they did a pig to monkey heart transplant model. And what they did is that they excised a gene that's responsible for post-translational modification of proteins. And the gene is called alpha-1,3 galactosyltransferase gene. And this was basically removed from the genome because this is responsible for the addition of some of the galactose 1,3 alpha galactose carbohydrate to proteins. And so they inserted this to the genome of the pigs before transplantation. And they did some pigs just with that modification and some pigs with additionally with the complement modification we discussed before. And then they looked at the outcomes of these pigs, of these pig hearts in the monkeys. And what they found is that the addition of this knockout for the alpha-1,3 galactosyltransferase gene, which is abbreviated GTKO, resulted in significant prolongation of the life of the transplant. And so the transplants were living over 50 days. And it didn't seem to be modified much by actually the presence or the absence of complement. But this highlighted the role of this, and many other experiments highlighted the role of the carbohydrate xenoantigens specifically in xenotransplantation as an immunological barriers, and the importance of actually doing this genetic editing to get rid of the enzymes responsible for these post-translational modifications. Since then, 3 major carbohydrate antigens have been recognized. One of them is abbreviated GAL, which is the one we just discussed. One of them is abbreviated NU5GC, which is basically added on by the enzyme called CMAH. And then the other one is called SDA. And basically, after a series of experiments, we've recognized that it's important to actually have these 3 genes knocked out in xenotransplant models to prevent sort of this early acute rejection or hyperacute rejection against the carbohydrate antigens. So far we've talked about the importance of preformed antibodies, the carbohydrate xenoantigens, and the complement system. The next one that is also actually very important is the coagulation system. So the coagulation system of the pig is different from the coagulation system of humans, and they don't have the same, and the pig sort of regulatory proteins are different. And so they're not able to sort of regulate the human clotting system. And that's resulted in early graft loss from TMA and thrombosis, etc. And what I'm showing you here is an example of a study published in Transplantation about 20 years ago, where they looked at the coagulation system in xenotransplants from pigs to monkeys. And what they found is that after transplantation, there's a huge reduction in fibrinogen levels, and that this fibrinogen actually ends up being deposited in the glomeruli and in the vessels of the kidney in the form of TMA, which is shown in immunofluorescence on the right. And so this was also one of the earlier studies that sort of highlighted the importance of not only focusing on the complement and the immunologic mismatch, but also on the coagulation dysfunction. And this was followed by studies actually looking at gene editing to insert human regulatory factors for the coagulation system into xenotransplants. And so this was a study published in Xenotransplantation about 7 years ago, where they actually did genetic modification of the pig, where they didn't just do the genes for the carbohydrate sort of modification and the complement, which is human CD46, another complement regulator, but they also added some genes. They basically had some kidneys where they just did the carbohydrate and complement, and one group of kidneys where they did the carbohydrate, the complement, and the sort of thrombotic regulators. They added 2, which is EPCR, which is a protein C receptor, and then TFPI, which is tissue factor plasminogen tissue factor pathway inhibitor. And so these, which are negative regulators of the coagulation system. And then what they did is they noticed that the pig kidneys that had all of the genetic modifications, including those that sort of regulate the coagulation system, actually lived about a week longer compared to the ones that did not. And when they looked at the histology of the kidneys, which I'm showing on the right, they found that there was no evidence of TMA or coagulation in the kidneys of the pigs that had the genetic modification with the sort of negative regulators of the thrombotic pathway. But when they looked at the kidneys of the pigs, that did not have the genetic modification, when they explanted the kidneys and did histopathologic analysis, they found that most of these kidneys had evidence of thrombosis. And so this was another sort of experiment highlighting that the coagulation pathways and regulation of it with transgene is really important, for prevention of early allograft loss. And then the next advancement is the costimulatory blockade in xenotransplantation. And I'm not going to spend a lot of time on this just to be cognizant of time, but basically a lot of the earlier experiments with xenotransplantation were done with calcineurin inhibitors. And a lot of these earlier experiments had poor outcomes for many reasons. But really the utilization of costimulatory blockade in xenotransplantation has really advanced sort of our immunosuppression in xenotransplantation. And so two of the other agents that have been used are CTLA-4 Ig, which blocks the costimulatory interaction between CD28 and CD8086. But the most important one is actually the introduction of CD154 antibodies, which block the interaction between CD40 CD40 ligand. And because in xenotransplant models, the CD154 antibodies seem to be the most potent in terms of prevention of rejection. But this sort of took time to reach because the earlier molecules that used that were CD154 monoclonal antibodies had a lot of prothrombotic issues. They were activating platelets and causing thrombosis. And so it took really a long time until now we have CD154 monoclonal antibodies that are potent immunosuppressive agents, but do not have this side effect of thromboembolism. And I'm going to discuss this in one of the future xeno models. Okay, so with all this information about and all these advances in understanding the carbohydrate xenoantigens, the importance of the coagulation system, the importance of the complement system, doing all this genetic editing, and then the CD154 monoclonal antibodies, this has really helped us translate the pig to non-human primate data to pig to human data. And so the first xenotransplant that was done in this way was done in a pig, were two cases that were done by Robert Montgomery at NYU, where they transplanted pig kidneys into brain dead humans, and which I'm showing on the left. And these kidneys were placed externally, sort of in the thigh area for ease of access and biopsy, etc. What they did is they transplanted what they called thymo kidneys, which basically means it's a combination of the kidney and the thymus. And the way they did that was they got these pigs 2 months before the organ donation. They removed the thymus and they implanted the thymus under the renal capsule, because in previous models that they had looked at, this was helping induce sort of a tolerance or less rejection. And then 2 months later, these pig kidneys were then were transplanted into the brain dead humans. And what you're seeing on the right is how they collected the urine output of these pigs. And what I'm showing here is sort of the kidney function, how the kidneys worked. The black line shows the GFR over time, and then the bars show the urine output over time. And what you can see is after transplantation, in both these patients were not on dialysis before this, and they had some kidney function. But after transplantation, you can see in both cases that the GFR increased significantly, the urine output increased significantly, and so the kidneys seemed to work at least early on. This experiment was only allowed to continue for 54 hours per the FDA regulations, and so all we really know is that this first thymo kidney to human transplantation, that the kidneys worked for 54 hours, but then the experiment had to be stopped. But importantly, they looked at the histology of these kidneys at 54 hours after transplant, and what they saw is basically there was no evidence of rejection on light microscopy, which is shown in the top panels. But what they saw, interestingly, was in one of the two recipients, there was some early mild C4D deposition, which you could argue may be an early antibody response. But this, at that time, there was no peritubular capillaritis or glomerulitis. And the EM, there was no sort of major changes of endothelial injury. But this really was a big advancement in terms of saying, okay, we can do these transplants in humans, and potentially this can be something that can maybe last longer and needs to be explored further. So the last step before I'm going to get to sort of the real human kidney transplant that was done was this paper from Nature last year by Tatsuo Kawai's group, where basically they created what they called the humanized porcine donor. which is the pig that they thought would be most likely to do well in human transplantation. And what they did is basically they combined the prior information that we had from the prior experiments. And they basically, the first step they did was they did a triple knockout where they knocked out the 3 carbohydrate genes. And so they made these pigs that were basically didn't express any of them. They then made a second group of pigs that had what they call 3KO70G, which is a triple knockout and with the insertion of 7 transgenes for which they included genes for the complement pathway and the coagulation pathway, as we discussed before. And then lastly, for the last group of pigs, what they did is they actually did also retroviral inactivation. So they removed the retroviruses from the genome. And what they called this pig 3KO70GRI. And they transplanted all these to monkeys. The immunosuppression they used in the study was they did induction immunosuppression with anti-thymocyte globulin for T cell depletion, anti-CD20 for B cell depletion, anti-CD154 for co-stimulation blockade, and then standard triple immunosuppression with tacrolimus, mycophenolate, and prednisone. So pretty heavy immunosuppression. And what they did and what they found was basically that they compared the outcomes of the pigs that either had the triple knockout alone, which is just knocking out the carbohydrates, and the ones that had the genetic modifications of knocking out the carbohydrate plus the complement gene insertion plus the coagulation regulator gene insertion. And so what they found is that the pig kidneys that had all the genetic modifications, so carbohydrate plus complement plus coagulation, had much, much longer graft survival compared to the pig that just had the carbohydrate modification. And in fact, these pig kidneys lasted over 2 years, which was, really remarkable and is the longest time that pig kidneys have lasted in non-human primates. And so this is what led to sort of this model to be translated to humans. And so this led to sort of the kidney transplantation, the first pig to live human kidney transplantation in sort of modern times, which was done at the Massachusetts General Hospital on March 16th of this year. The transplant was done by Dr. Kawai and Dr. Elias, which is shown on the left. And on the right, we show you the picture of both and with the patient himself, Mr. Slayman, and then Dr. Riella, who was the director of the kidney transplant program here. And so the transplant was done that day, and the induction immunosuppression that was used was similar to what was used in the monkey: B cell depletion, T cell depletion, co-stimulation blockade, and then with the addition of also C5 terminal complement blockade plus regular triple immunosuppression with TAC, MMF, and prednisone. The way this was sort of developed was that it was a kidney transplant candidate who was basically at high risk of basically death and was not going to be getting a kidney transplant from a human. He was a 62-year-old man with end-stage kidney disease, diabetes, and coronary artery disease. He had a prior failed transplant and was now back on dialysis. He had really significant vascular issues and was requiring frequent procedures. So he lost his sort of arm grafts, one of his leg grafts, and now was dialyzing via a femoral arteriovenous graft. And he was clotting the graft frequently. And so there was a lot of worry that his access is, he's going to run out of access in the next year. He had no living donors. And based on his blood type, he was anticipated to have to probably wait another 4 or 5 years for a transplant, which was thought to not be realistic for him. And so this was sort of offered to him through a compassionate use through the FDA. And I'm not going to go through a lot of the details because this is about to come out in a manuscript soon. But what I'm allowed to share with you is that he had immediate graft function after the transplant. And so he was taken off dialysis. He was doing fine for about a week, and then he had a significant rejection event on post-op day 8. And with that, he had sort of significant deterioration of the kidney function. And at that point, he was treated aggressively with heavier immunosuppression, steroids, thermoglobulin. And then the rejection got better. He was actually, his kidney function improved, and his creatinine ended up being around, high 1s, low 2s. He was discharged home 2.5 weeks after transplant. Obviously, there was a delay with all the rejection and all of that. And overall, he actually did pretty well. There were some issues with like volume management and, electrolytes and stuff like that, which is, not uncommon after transplant. But he overall did pretty well until about 2 months after transplant, where he was seen in the morning in clinic. He was doing fine. His labs were fine. And then in the evening, he just had a sudden cardiac death, which was thought to be unrelated to the transplant. But the details of a lot of this is going to be published pretty soon, and so I'm not gonna go over a lot of that details now. So the final remarks before I pass, because I think I'm over time, is that another thing to think about is the physiology of this kidney transplant, xenotransplantation, and where it's going to fit in our human transplantation models. And so we know that the kidney does a lot of other things beyond just glomerular filtration. We know that the kidney is important for serum osmolality and water balance, for blood pressure regulation. And from the experiments so far we have, it seems that the pig kidney is able to do this. The other questions are about erythropoiesis. So the pig kidney does make the pig erythropoietin, but it seems like the pig erythropoietin may not work on the human bone marrow. And so most likely these people who receive kidney xenotransplants will still need to use recombinant erythropoietin like they do on dialysis. And then there are still some unanswered questions about the response to FGF23 and PTH and stuff like that that we're still working on exploring further. And then the last thing is whether sort of how is this pig xenotransplantation going to fit into our human transplantation when it's well established? Is it going to be destination therapy where you could get the pig kidney just as that being your final organ? Or is this going to be a bridge to human kidney transplantation in people who let's say have a long waiting time, don't have living donors? So a lot of questions that we don't know yet. So to summarize, xenotransplantation is a possible solution for the solid organ transplant shortage. And advances in the gene modification and immunosuppression have improved the outcomes in the pig to non-human primate xenotransplantation. The data from the non-human primates and the early human data is really encouraging. But how xenotransplantation will fit into the scheme of human transplantation is not clear to me at this time. So I think I will stop there because I'm past 11, and I'm happy to take any questions. I hope so. Thank you for the invitation.